Pelayanan gawat darurat merupakan bentuk pelayanan yang wajib dimiliki oleh setiap rumah sakit. Pelayanan ini diselenggarakan guna mencegah kematian dan kecacatan pada penderita gawat darurat, menerima atau mengirim pasien rujukan, menanggulangi korban musibah massal dan bencana, serta memberi pelayanan berkualitas tinggi dalam mengatasi problema akut pasien. Selama pandemi berlangsung, pelayanan gawat darurat harus sedemikian rupa melakukan berbagai persiapan dan penyesuaian guna tetap menjalankan fungsi dan tujuannya secara maksimal. Instalasi gawat darurat Rumah Sakit idsMED berusaha semaksimal mungkin menerapkan standar prosedur pelayanan gawat darurat dengan tetap memperhatikan protokol pencegahan COVID-19. Kami menerapkan suatu strategi untuk mencegah COVID-19 menyebar kepada pasien lain yang tidak terinfeksi COVID-19. Kami berusaha memberikan keamanan selama melakukan pelayanan kesehatan, bukan hanya kepada pasien yang datang, tetapi juga kepada segenap staf kesehatan yang mendedikasikan dirinya untuk menolong pasien. Kami percaya bahwa suatu sistem dan protokol yang baik harus didukung oleh infrastruktur dan peralatan yang terbaik.
Aduh dokter, sakit dokter.
Ya tolong, bednya dibikin setengah duduk. Ya, tolong Pak. Bantuan Pak, makan dulu ya Pak. Apa yang dirasain Pak?
Sakit dokter, dada saya sakit dokter.
Rasanya kayaknya ada apa?
Sedikit.
Selamat pagi, Assalamualaikum warahmatullahi wabarakatuh. Salam sejahtera bagi kita sekalian. Shalom, Om Swastiastu, Namo Buddhaya, salam kebajikan. Apa kabar semua Bapak Ibu yang berada di rumah? Semoga tetap sehat walafiat dan juga tetap semangat. Selamat datang saya ucapkan kepada seluruh peserta webinar hari ini, Sabtu tanggal 19 September tahun 2020. Topik kita hari ini adalah Future of Hospital Emergency Care yang merupakan kolaborasi pertama idsMED Learning Academy dengan pihak internasional. Pada webinar kali ini kita akan membahas tentang masa depan pelayanan kegawat daruratan di rumah sakit beserta tantangan yang dihadapi. Event hari ini kembali dimanage langsung oleh idsMED Learning Academy. iLA merupakan suatu entitas independen yang pembentukannya diprakarsai oleh idsMED sebagai bentuk komitmen untuk menjadi solusi bagi pelayanan kesehatan di Indonesia. Dan juga terselenggaranya event ini tidak lepas dari dukungan langsung oleh idsMED Group dan juga Stryker. Bapak Ibu peserta webinar yang saya hormati, seperti yang kita ketahui, pandemik membuat beberapa pihak, terutama tenaga kesehatan, untuk bekerja lebih keras lagi daripada biasanya. Bahkan beberapa dari mereka telah menjadi korban dan juga wafat selama menjalankan tugasnya melayani pasien. Oleh karena itu, mari pada kesempatan ini kita jadikan kesempatan ini untuk mengenang para pahlawan korban COVID-19 dengan menyaksikan satu video berikut ini. Dengan video tersebut, kita semua bisa mengenang dan mendoakan berjuang untuk melawan COVID-19. Bapak Ibu, selanjutnya kita akan mendengarkan kata sambutan dari Presiden idsMED Indonesia, Bapak Rufi Susanto. Kepada Pak Rufi, saya persilahkan.
Selamat pagi semua. Pada pagi hari ini, pertama saya ingin berterima kasih dulu kepada Dr. Eka Sakti yang hadir di sini nanti. Saya juga terima kasih kepada Dr. Wahyu, Dr. Michael, sama Dr. Ali yang nanti akan menjadi moderator. I think pertama mungkin sebagai idsMED saya ingin berterima kasih kepada mungkin mewakili rakyat ya, untuk terima kasih kepada dokter semua bahwa di situasi ini you have apa ya namanya unconditionally right work ya, all that you can to save our people gitu ya. Saya rasa mungkin not everyone, nggak semua dari mereka itu punya kesempatan untuk mengucapkan terima kasih. Nah, mungkin saya mewakili dari mereka untuk mengutarakan my gratitude and also my thankfulness to all our doctors ya. And of course kita harap there's no more doctors yang menjadi korban, I hope, right? And also we hope that rakyat kita mulai makin sadar. Nah, today acara emergency ini kalau untuk semua dokter, bahwa the emergency situation di Indonesia ini memang is different, right? Karena Indonesia itu is big, 17.000 pulau, there's so many different standard, right? But I think sebagai IDS udah sekitar 20, saya udah berkecimpung 20 tahun lebih. I see there's a lot of improvement ya, in terms of our emergency, right? I think ada satu lagi gerakan yang kita dukung namanya Kreki ya. Itu memang kita keep on campaigning about doing CPR gitu. Jadi I think everyone is trying to do their job to make sure that our so-called our standard will be higher and higher. Now I hope, right, para peserta bisa mendapatkan sesuatu, ilmu atau whatever ya, to bring home, and thank you ya udah mau spend time hari Sabtu ini untuk datang menghadiri webinar kita. Dan sebelum saya tutup, I want to thank you kepada iLA. I know you have done a lot. Thank you very much. And also I want to thank my Stryker friend. I think Michael, I hope you are here, and I want to say thank you, for helping us with the speaker. And I hope itu semua nanti akan berguna untuk semua. Terima kasih and have a good learning. Thank you.
Terima kasih Pak Rufi atas kata sambutannya. Selanjutnya kita akan mendengarkan kata sambutan dari Mr. Ed Hutcherson yang merupakan Emergency Care Marketing Manager dari Stryker. Please welcome Mr. Ed Hutcherson.
Good morning everyone from Sydney, Australia. It gives Stryker great pleasure to be able to partner with idsMED Indonesia and participate in this webinar on the future of hospital emergency care. At the heart of what we do and believe is making healthcare better. We do this by collaborating with our customers to develop innovative products and services that ultimately improve the lives of patients. And this is expressed through our mission. Together with our customers, we're driven to make healthcare better. Our core values of integrity, accountability, people and performance guide our behaviours and actions. We do what's right. We do what we say, we grow talent and we deliver. These values are part of our DNA and are fundamental to how we execute our mission. We understand that in today's challenging healthcare environment, our customers need solutions that improve quality, efficiency and the patient experience. These challenges are creating opportunities for us to make healthcare better for our customers and for the patients that they serve. Enjoy the webinar and I wish you all a very happy and safe end to the year.
Thanks Mr. Ed for the warm welcome speech. Baik, selanjutnya saya akan menginformasikan beberapa peraturan terkait webinar kita pada hari ini. Yang pertama, sesi tanya jawab akan dilangsungkan setelah masing-masing sesi materi selesai dilaksanakan. Yang kedua, pertanyaan dapat langsung diberikan melalui link atau scan barcode yang tersedia. Pertanyaan juga boleh diajukan dalam bahasa Indonesia dan akan dibantu terjemahkan oleh moderator. Yang ketiga, sertifikat akan diberikan dengan ketentuan peserta webinar mengikuti minimal 80% dari keseluruhan webinar dan mengisi form survei yang muncul di akhir acara untuk memastikan nama yang tercantumkan dalam sertifikat sudah benar. Dan yang terakhir, semua rangkaian acara hari ini akan di-upload di channel YouTube iLA Indonesia. Dan jangan lupa subscribe untuk mendapatkan update terbaru dari kegiatan selanjutnya. Bapak Ibu, kita akan langsung masuk saja ke dalam webinar atau acara inti kita pada hari ini. Acara ini akan dipandu oleh moderator yang pastinya sudah kita kenal sepak terjangnya di dunia emergency, yaitu Dr. Wahyuni Dian Perwati, spesialis emergency. Beliau menyelesaikan pendidikan doktoralnya di Fakultas Kedokteran Universitas Hasanuddin Makassar. Dalam kesehariannya, beliau adalah instruktur American Heart Association dan juga Head of Emergency Department di Siloam Hospital Group. Kepada Dr. Wahyuni, saya persilahkan.
Selamat pagi Bapak Ibu dokter sekalian. Assalamualaikum warahmatullahi wabarakatuh. Selamat datang di acara interaktif live collaboration webinar yang diselenggarakan oleh idsMED Learning Academy bersama dengan PDEI. Very happy that we have our special speaker today. Ya, jadi pada pagi hari ini kita punya dua orang speaker. Our first speaker is Dr. Mike Levy. He is a EMS Medical Director from State of Alaska. And our second speaker is Dr. Haedar. He is a clinical lecturer and consultant emergency physician. Untuk mempersingkat waktu, saya akan memperkenalkan our first speaker. Jadi kita akan bacakan CV beliau. Dr. Mike Levy, he is an EMS Medical Director, State of Alaska, USA. And he is also a Chief of Medical Advisor, Stryker Emergency Care. Oke, kita akan menyapa beliau. Hi, Dr. Mike Levy.
Hello.
Hello, Doc. Good morning from
Hello.
Indonesia.
Thank you so much. And my greetings from Anchorage, Alaska.
Oh, okay. Di sana udah malam ya Bapak Ibu ya. Okay. So, Dr. Mike Levy, how are you today?
Doing quite well, quite well. We're into our fall today. It's a little bit brisk out, but it's pleasant, and I'm doing quite well, thanks. I hope you are as well.
Yes. Ya, Bapak Ibu sekalian, Dr. Mike Levy ini sangat berpengalaman, terutama untuk EMS. Jadi kita akan sama-sama mendengarkan pemaparan beliau selama 40 menit ke depan. So, jadi slide-nya beliau adalah tentang Future of Hospital Emergency Care, Observations from Alaska. Dr. Mike Levy, please, you have 40 minutes to share your slide. The time is yours.
Thank you. I believe you're going to run the slides from your side. Is that correct? Okay. Next slide, please. Thank you. So these are my disclosures. I want to say at the outset just how happy I am to be here. Certainly wish I were there in person, but that is not possible today. Give me just a second to get my screens oriented here. One just went away. I want to thank Stryker for having me here today, and I want to thank IDS Medical for sponsoring this as well. Next slide, please. As has already been described, I'm what's called an emergency medical services physician. I am subspecialty board certified in emergency medical services. I'm residency trained in emergency medicine as well as in internal medicine. So I did residencies in both of those specialties. I practice these days mostly EMS medicine. I'm also the incoming president of the National Association of EMS Medical Physicians. And I'm sorry to act a little distracted here, but my screen keeps changing from my presentation to leaderboard. So I I'm going to talk briefly about Alaska and U.S. healthcare. I'm not a health economist, but I wanted to sort of put it in context of our similarities as I perceive them and where I think our systems could improve, and certainly our system could improve. And I hope to learn more about yours as well. I want to talk about two different models of healthcare delivery we're now using in Alaska that, and have been using for some time, that I think can help us move forward and do a little bit better than we've done to this point. Next slide, please. There are some questions that you've already had you've been able to answer, and I think you'll find as we go through the talk that those questions, you'll be able to answer those as we go, but I can go over them at the end as well. Advanced slide, please. So Alaska is the great land, great North America. Next slide, please. And you can see we have volcanoes and we have grizzly bears and salmon running around. These are the dimensions of our state, about 1,700,000 kilometers squared, the width 39 kilometers. Advanced slide, next slide, please. The length is 2285 kilometers. Next slide, please. And our population is just 710,000 people for our whole state, and 300,000 of those live in Anchorage, Alaska itself. Next slide. When you look at Alaska versus the United States, you can see that many of the maps you look at misrepresent the size of Alaska. It's quite large. It's a third the size of the entire United States. And our archipelago stretches all the way out to California. Our panhandle stretches all the way out to Florida. So we are a very, very large area. Next slide, please. Now I compare that to Indonesia. When I was preparing for this talk, I found it quite fascinating. We have many similarities in terms of our geography. You're an island country, world's largest island country, I discovered, and the 14th largest country. You have more than 17,000 islands. That beats us by a few. We have quite a few ourselves. Your population dwarfs us. You're much more populated than the United States. But I think given the fact that we're a very dispersed geographic entity, I think we have similarities. Next slide, please. And this just tells me more about it than it does about you. I've had the pleasure to have been to Bali once with my family, had such a wonderful time, and such hospitality and wonderful people. I treasure that trip. Next slide, please. When we look at countries, other similarities that I noted, America, the United States of America, does not have free healthcare. It does not have universal healthcare. Much of our healthcare is still what we call fee for service, which means you have to pay a doctor to see them, and our government doesn't pay a subsidy for that. And when I look at the map of the world of countries like that, I notice that it seems like Indonesia has some similarities with us as well. So probably more for us to discuss there as well. Next slide. So with regard to US healthcare and US dollars, and these are a few years out of date, so it's only gotten more expensive, but each person in the United States spends over $9,000 on healthcare spending. And the US healthcare budget is by now over 17% of our gross domestic product. So this causes a lot of alarm in many circles regarding how much we spend on healthcare and whether the value equation for the healthcare dollar spent makes sense. So the way people have their healthcare covered in the United States is a combination of private insurance and some government programs. Medicare typically takes care of our elderly. Medicaid takes care of folks who otherwise can't afford healthcare. There's no universal healthcare in the United States. And as much as 20% of our population, 40 million people, may be completely uninsured. Healthcare facilities are largely private sector entities. 58% of those are nonprofit, 21% are government owned, and 21% of healthcare facilities in the United States are done for profit. Next slide, please. So just a little blurb here. Our neighbors to the north have a much more, at least cost-efficient system than we do. Canada's healthcare is costs 4 times less than the United States healthcare system. And many people believe that the healthcare per dollar at least equals what we see in the United States. So, you know, we may have opportunities to improve the United States with regard to our healthcare spending. Next slide, please. When we look at the increase in healthcare premiums in the United States versus wages, you can see that the premium increase far outstrips wage increases. Medical bills in the United States are the #1 cause of bankruptcy, according to many sources, which I think you would agree with me. That's a very concerning figure, a very concerning figure. Next slide, please. So I'm an emergency physician, and I'm on the good side of this curve, I guess you could say, in that we seem to charge a lot for the healthcare we provide. Now, this is true. Next slide, please. It is certainly not inexpensive to come to the emergency department. You can see that when we have one of our higher level codings, it can cost $2,000 just for that experience. I would say in our defense, however, just real quickly, that when you show up in our emergency departments, most emergency departments are fully equipped. And so the amount of healthcare that is given to you at that point, or at least delivered, is quite a lot with regard to all the technology and the like. Whether that justifies the cost, one would have to question. Next slide, please. And why do people come to the emergency department? Well, they come in large numbers. The volume has increased from almost 129 million to nearly 140 million visits. And the most common reason for coming to an emergency department in the United States is abdominal pain. But quite honestly, in the United States, we see a lot of social ills, and we take care of a lot of social ills in the United States having to do with mental health and a lack of overall mental health facilities in the United States, as well as a lot of substance abuse. So alcohol, heroin, methamphetamine, with a lot of recidivism is a very, very common daily task that I would undertake as an emergency physician. Next slide, please. So when you look at Alaska, this pretty picture in my left upper is a picture of Anchorage, Alaska, with the backdrop of our mountains and our little skyscrapers and the like. That's the town of 300,000 that I live in. But Alaska mostly are small villages and small islands and very, very, very remote areas. So, for example, in the right lower quadrant, there is a place called St. Paul Island, where I had my first EMS service. It's a 4-hour airplane flight on an old prop plane to get there. And it's actually that red dot you see on the picture in the upper right out there in the Bering Sea. Next slide, please. 75% of Alaskan communities are not reachable by road. Now, since you're an island country, you may find that less interesting than people who live in our lower 48 of the United States. But this is an astounding thing from the United States standards. Basically, we're a roadless area. We have 24 acute care hospitals in Alaska, but 14 of those have less than 50 beds. So they're basically what we call critical access hospitals. 6 of the hospitals reside in this metropolitan area where I live, called Anchorage, and a place called the Matanuska Valley, we call the Mat-Su Valley. Next slide, please. So when we talk about rural and remote, actually in Alaska, we talk about frontier, super remote, and the like. But what's the difference? Next slide, please. Well, it comes down to how much of the place is connected by roads. Next slide, please. So when you superimpose that map I showed before, here's our road system in Alaska. And I always make the point that if you're buying a car in Alaska, you don't want to pay extra for a GPS in your car, because we either turn right or we turn left. There aren't that many big decisions as you'd have in a larger metropolitan area. So for the most part, we have roads only around this area where I live, and one road that goes up north there, that red line up to Prudhoe Bay. And the reason that road is there is because that's where the major oil fields are. And that's what's called a haul road, where the big 18-wheelers can go during the summer months. But other than that, we have, thank you for showing that, appreciate that. Other than that, we have no road system in Alaska. So people get where they're gonna get by plane, by boat, by dog sled. We have winter routes that are made in ice roads. So up in Prudhoe Bay, we can't get any production work done in there until it gets cold enough, 30, 40 below zero, so that we can go ahead and build what are called ice roads by laying water down on the tundra and building up roads where they can take these huge trucks and construction equipment. Next slide, please. Oh, one more time, please. Next slide. Go back one. Thanks so much. Oh, go one. Got it. All right. So define groups of healthcare beneficiaries. So it's not as if there isn't coverage in the United States, and there are some designated groups who do get coverage, which for them is free or relatively free. So a thing called Medicare is our care for people over age 65 and a few other breakout groups. So once you're of a certain age, then you pay less for your health care, but there's still what we call co-pays. Veterans, if you're a veteran of the United States military, then you can qualify for veterans care in their system of hospitals and clinics. And then if you're Alaska Native or a Native American or Pacific Islander, then there are specific hospitals and places for care that are free for that group. But the rest of America doesn't have access to those systems, but those systems do exist. And in Alaska, in particular, the Alaska Native health system is pretty important. Next slide, please. So when you look at our state, and again, put this on the scale of a really big state, here's where the hospitals exist, the tribally owned hospitals. That arrow at the top is up towards Prudhoe Bay, that place we were talking about before. And then as you go down the coastline, these are the other hospitals that are associated with the tribal system. So those are small hospitals that nonetheless can provide acute care in a relatively limited fashion. Although these days, those hospitals right there actually have CAT scans and some more advanced technology that they didn't have when I was actually practicing down there. Next slide, please. So here's our tertiary care hospital. This is the Alaska Native Medical Center, which is the tertiary referral hospital for all of the Alaska Native medical system. And it's a level 2 trauma system, very sophisticated, 168 beds, 250 physicians on staff, a research department, a lot of stuff going on there. Next slide, please. However, if you go out into Barrow, that dot on the top of the map I showed you before, they fortunately have this beautiful new facility, but it's a 10-bed critical access hospital. Next slide, please. This is what Barrow looks like, these beautiful little children, and then below that is a picture of a typical village. The houses are raised above the permafrost. It's a very boggy area. It's right on the ocean, and the ice and the like that occurs, during wintertime. And so the houses are elevated, one, to keep them out of the water, and also to keep from making the permafrost thaw and causing things to sink. Next slide, please. Next slide, please. And next slide, please. The picture of the dot before that I showed you shows you the regional clinics that we have. And that picture before was a picture of a regional clinic. So that has no inpatient capacity, but it's a place in these more remote areas where people can go for healthcare. Go back one slide for me, please. I think I might have missed a slide here. And go back one slide further, if you would. Okay, go forward, please, 2 slides. So what we have then is we have these regional clinics, of which we have quite a few, and we have the sub-regional hospitals. And so it provides a pattern of referral of healthcare where we can bring people from a small regional clinic to a small critical access hospital, and if need be, bring them to that central point at the tertiary care hospital. Next slide, please. And you can see that our referral pattern was pretty much like people from one part of the United States referring clear across the United States to another one. So you'd ask yourself, how in the world can we staff clinics like this? We have a very large number of small clinics, and usually we have a pretty low number of physicians willing to staff those kind of things. So, and this gets to one of my points about this talk. I mean, how can you staff for a small number of people who cannot access this care? If you get them to care, you're gonna have to spend a lot of money to fly them out and all these kinds of things, which might be for very minimal problems. How do you do it? Next slide, please. Well, you do it like this. We have a thing called the Community Health Aid Program, the CHAPS program. Next slide, please. So the CHAPS program is basically what you might refer to as a barefoot doctor program. This actually was developed way back in the 50s, and it had to do with the outbreak of tuberculosis and other infectious diseases that needed to be taken care of, but there was no way to provide that care. So this idea of taking people with minimal education and teaching them specifically to handle certain problems became the footprint that evolved into this thing we call the CHAPS program up here. It turned out that the federal government endorsed it, and actually it's funded through the federal government now. Next slide. So there are now 550 community health aid practitioners located in 170 rural Alaska villages. They use a guideline manual to help them walk through the different medical problems and things they might encounter. They have an established referral relationship, so they're supposed to talk to a referral physician as soon as they can, and they often would fax or do a verbal communication with the physician. These practitioners are selected by their communities, are usually part of that community, and then they're sent back usually to Anchorage, but there's other places where they can get their training, which amounts to 3 or 4 week training sessions, and then they get some clinical time in the hospital to learn the hands-on. Next slide. So this is what that map looks like. You go from this very low number of larger hospitals and referral centers to the CHAP village clinics, which are typically just little houses or just a very modest arrangement where the villagers can come in and be taken care of by one of the CHAPS practitioners. And the CHAPS practitioners, as I said, are usually one of the people from the community, so typically very, very well accepted member of the community to begin with. Next slide, please. So it used to be there was a textbook for this. Now as things are, it's evolved into eCham. So this is the core content for the CHAPS program. Next slide. And I hope this projects well enough that you get an idea. I don't expect you to get through this whole thing, but basically they're taught how to access information and the type of information they need to access. So the patient comes to them and they ask questions that are scripted through this type of online resource, and it leads them sort of algorithmically down how to solve a problem. And you can see on the column on the right, or maybe you can't, but I will tell you that they can click boxes if it's an eye problem or a mouth or tooth problem, circulatory, and then it opens up a pathway to help them walk through the different problems that might address the issue for the patient. Next slide, please. So this is the type of script they would do, pretty much like we as medical practitioners would ask, but they have not had the education we've had, but they can basically work their way through this. When did the problem start? What exactly is the problem? What does it feel like? What type of pain is it? These are all common things to we medical practitioners, but they actually walk them through it in a scripted manner like this, so the information can be obtained, and then if they're later communicating with their referring physician, they can put together a thoughtful presentation for the practitioner to go further with this. These type presentations can also be done secondarily with telemedicine. There's a telemedicine infrastructure as well. So it turns out that it works into a pretty good and robust system, and a system that ultimately provides care that's accepted by that community, is safe, and it's well regulated and has good oversight. Next slide, please. So it also spans the spectrum of problems that we might see. Mental health, as I stated before, is a major ongoing issue for all of our health systems. And they are given pathways to help assess mental health issues, whether it be acute, or more chronic. So these upper boxes, bullets, refer to more chronic mental problems, ideas of whether we're encountering a violent patient and how to address that. So it's a very good and a pretty thorough resource to help these folks navigate this pretty complex environment in which we work. Next slide, please. These are times when they're supposed to report back. Again, a little hard to read that, but I want to give you just a feeling for how they can navigate. You can see the tabs above, etc. So it works out, you know, a pretty good system to solve a pretty complex problem. Next slide, please. Okay, then there's follow-up instructions. Again, this probably looks pretty familiar to those of you who practice emergency medicine or in clinic work. They also, if you look here, you notice that there's things about medications. These practitioners can prescribe medications. They can prescribe antibiotics. They can prescribe pain medications. Now, the prescription is actually coming through their referring physician, but they're not necessarily talking in real time about that because of problems we have with communications and the like. So there's pathways for them to initiate therapy for ear infections or and the like, which is taken through this. And then they're basically also the dispensing pharmacy. They have medications in the clinic. They write on that how much they're supposed to take and how often. And so it's an interesting problem solved by this method. Next slide, please. I think I missed one slide there, but I will tell you that they also do procedures. So unless I got my slides a little bit out of order, they also have things on such things as draining abscesses and the like, and they show them how to inject the abscess, how to incise it with a scalpel, how to spread the abscess, how to irrigate it, how to pack the abscess, and how to do later wound care on it. So it's an interesting thing for me. I hope you find it interesting as well. So next slide, please. Go back to that former slide. I'm sorry, I want to mention that 1 second. So another thing this is branched out into is dental care. In Alaska, dental care is very hard to obtain unless you have private insurance. It's expensive, and unfortunately, there's not much what we call pro bono, that is non-fee-for-service dental care available. And that was true for the native health system as well. So they started making these community health aid dental aids. They can do basic dental care up to including tooth extractions. The way the healthcare system works in the US, this would be very difficult to achieve in Anchorage, Alaska, for example, despite the need, because quite honestly, there would be financial concerns about people who were not licensed through the same pathway that dentists were doing this kind of care. Whereas in a system like the native system, where they're more pragmatic, this becomes a really great solution. And this has been in place for a number of years, and everybody seems pretty happy with it. We're not seeing any horror stories or terrible outcomes or the like. So people are not suffering with dental problems by lack of having access to people. So, you know, good on them for coming up with a very pragmatic solution to a real problem and not getting constrained by doing it the way it's always been done. So for me, great idea. Next slide, please. Okay, so again, our systems are alike in some ways, certainly different in other ways. So just to talk about emergency medical services in the US, this may be quite familiar to most of you, and maybe it isn't, but in the US, in the pre-hospital environment, so in the field, out of hospital, we have our EMS service. And our EMS services are staffed by pre-hospital practitioners who have various levels of training and education and skill sets. Our lowest level of training are just first responders. So they're there to stop bleeding and provide CPR. We have our EMT basics, who are another step beyond that with their training, about 125 hours or so of training, all the way up to our what we call mobile intensive care paramedics or paramedics. And paramedics are usually about a 1,500 hour schooling with internship and the like. Paramedics in the US, by and large, through offline medical control, we call it, through protocols and standing orders, can do a number of things. They can give medications. In my system, they give medications such as fentanyl, midazolam. They do rapid sequence intubation using a sedative medication such as ketamine or etomidate, using rocuronium as our typical drug, and procedures that could include such things as needle thoracostomy, cricothyrotomy. So we have a group of practitioners who are very skillful in emergency practice, but we've not been able to leverage them the way we would like for providing a bridge in the community for the kind of care we could provide. Now this is changing, and we're getting into a realm called our mobile integrated healthcare, where we use paramedics in novel ways. These are called community paramedics. This is an example that I want to show you now in the last few minutes of the talk about our community outreach referral and education program we call our CORE program. And so this is at the Anchorage Fire Department in Anchorage, Alaska, where I'm the medical director. Next slide, please. So with the community assessment, the needs assessment, we found a priority of needs, which included the priority included our poverty, our social determinants of mental health problems, problems with healthy behaviors in the absence of some, substance misuse, and the lack of access to health care. Next slide. As a result of that, we as the fire department wanted to see if we could help decrease the amount of use of EMS for people with these problems who are then brought in a kind of a vicious cycle to an emergency department without resolution of their problems. So when you look at our system, we have what's called basic life support. That's our low acuity ambulances. And with that, in calendar 2017, we had about 10,700 basic life support runs, and that's a little less than half of our responders. In that category, we had our top 50 patients accounted for 7% of all of our transports in 2017. And our top 150 patients accounted for 1% of all patients and 10% of all EMS responses in 2018. If you look at how much substance abuse we're dealing with in behavioral health, almost 3,000 runs in 2017 for substance abuse, alcohol abuse, behavioral overdose problems. And in 2018, similar sorts of number. Also, our police are responding similarly to a huge number of calls as well. Next slide, please. So when we look at these numbers and we look at the top encounters, the top users, we find that the percentage of calls can be up to 10% just of these top users. If you look at the top 5 averaged, using up a huge amount of our resources. Next slide, please.
Your time is another 10 minutes.
Thank you. So we looked at this across the board in terms of the fraction of the high users and the resources that they took. And you can see that that blue square stays pretty constant as a large percentage of the overall runs. Next slide, please. And next slide, please. Next slide, please. So we looked at the dollar value of our top 50 users. And if you look at this, it's pretty astounding. So Medicaid, Medicare, VA, those are the ones I told you about that we charge for user groups. So just these top 50 people were using almost a quarter of all of the spending. So the total amount was 1.1 million for Medicaid, for example. And these top users we were consuming $270,000 a year on this top 50. So you can see where this is going, the lay of the land there. Next slide, please. At the same time, the hospitals weren't providing any actual solution to this. We just kept in this vicious cycle. So this is the next year with similar kinds of numbers. Next slide, please. So we're looking at our Medicaid, AFD, EMS transport billing and payment. And you can see that the actual amount that we get paid is a fraction of what we actually charge, but it's a fair amount of money. Next slide, please. And then you compare that to the people of the top 50 and how much we collected of that from them. So almost 10%. Next slide. And so I guess on the one hand, you could say, well, you're collecting money. Maybe that's good if that's what you want to do. We find this as a bad thing because it consumes the resources that are supposed to be there for the actual emergencies. And unfortunately, although these are personal emergencies, they're not really doing what we need for the community. Next slide, please. So our objective was to identify the high users, the reason that they activate. Next slide, please. And then to try to help them using the quadruple aim method. Next slide. Next slide. And next slide. So we want to meet the users, improve patient care. We want to reduce their costs, and we want to improve the overall health and wellness of these people. Next slide. And next slide. So we want to reduce that burden as well. So here's a case study, and this will be kind of where we'll wind up here in just a couple of minutes. But this is one particular individual, client number 14, chronic health, substance abuse, 42-year-old woman. She actually had 2 separate coronary angiograms done at 2 separate hospitals because after her first heart attack, she had a persistent EKG change that looks like a STEMI. So before checking records, the cardiologist actually did 2 for the same false positive. So in 2017, 36 transports, and with this, she had about $32,000 in expenses just from that, just from the ambulance itself, and then the hospital visits on top of that, minimum $118,000 just for those transports. Next slide, please. 2018, similar sorts of numbers, going up to $220,000 just for her hospital bills and ambulance charges. Next slide, please. So we enrolled her in the program. She'd had 43 transports in the 6 months prior to enrollment. Next slide, please. After enrollment, she had 17 transports. She had a 60% reduction in her calls, and the net savings was at least $55,000. Next slide. Next slide. So what did we do? We enrolled her, we found out who her doctor was, we made calls for her. People would send her out of clinic without her medications, we'd pick her medications up for her, and we'd be somebody she could call for support when she got nervous. Next slide, please. Okay, and these are similar sorts of stories where we caused significant reduction just by that those simple interventions. Next slide, please. And next slide. So what does this mean? So we should just do this, right? Well, it costs the fire department $200,000 in salaries to backfill the position that we're using for this. And we also lose transport revenue. So we're doing this because it's the right thing to do. But we've had a hard time getting the system to realize the value, which we can demonstrate to them, and actually help us pay for the position to provide this better health care. So right now we don't have a sustainable model. This is something that happens in mobile integrated healthcare, unfortunately. But you have to admit, it's a great idea and the way things should be. Next slide, please. So when I say the future of healthcare, this to me is the future of healthcare. We need to think differently about how we deliver the care. We all have our places. I'm a physician. I want to keep my status and I want to keep my income, I guess. But at the same time, I'm not able to provide all the care that's needed to be given. And similarly, with the example I just gave you with our core program, we've gone to the administrators and said, we're saving you money. Well, the money's already obligated, so maybe we don't care about that as much. So you really have to get in front of the right people and you have to break through some barriers. But I think, and I hope that you'll agree that these are important programs which in themselves are very achievable. They don't require any high tech or anything to speak of. They just require that we get this done. Next slide, please. So in summary, at least with some of the demographics and the geography, it certainly seems that we share some characteristics. I think that I'd certainly like to know more about the structure of your healthcare system. I hope you learned a little bit about mine. I think that solutions for allowing for better and more efficient distribution of patients exist and be more satisfying to the patients themselves. And so as we all know, change is hard, but it's necessary. And I think currently the pandemic is leading to us to have to make changes we never thought we could make before, and we're making them at a rapid pace. So may actually be some opportunities that we'll find with this current situation we find ourselves in. And next slide, please. Okay, so quickly going through the questions, if you've not answered them to yourself already. How much do we spend? This was the answers people had. Very interesting. Good. Okay, next slide, please. And next slide. Good. What's the most common reason for a person visiting the emergency department? The right answer is abdominal pain. You would expect it to be something like heart attack or multiple trauma, but in fact, it is not. Next slide, please. And acute mental health problems, substance abuse are commonly treated in the emergency department. People got that one right. In a vast network of specialty referral centers, at home using community workers, at houses of worship. Next slide, please. What's the most common cause of bankruptcy in the US? People got that one right. I think you people are good test takers. You could see that one coming. But medical bills are a common cause of bankruptcy in the United States. Next slide, please. Is it possible for an unlicensed person to examine, treat, and give medications to a person with medical condition? Again, you got that one right as well. Yes, you can. I was just telling you about our program with the CHAPS program. Next slide, please. That is fantastic. Well, I thank you again. Thanks very much to Stryker for sponsoring me here tonight. Thanks to idsMED, and thanks to all of you who've taken time out from your day to listen to me. I hope this was helpful. Thank you so much.
Thank you, Dr. Levi. This is a very interesting presentation. I was very curious. Why so many people with abdominal pain coming to the emergency department in Alaska? Where is the cardiac arrest patients?
These are United States.
Oh, in United States, sir.
Yeah, I mean, it's, I can just tell you that's what it is. I think, you know, abdominal pain, I think, is the common pathway for a lot of different problems. Mm-hmm. So abdominal pain can represent, you know, as you know, so many things. And so that turns out to be the #1 thing that we see. I think, honestly, abdominal pain is anything from an abdominal emergency to a place where sometimes mental health issues or stress and the like sometimes manifest themselves as well. So maybe that's why it is that way.
Okay, very interesting, and I believe that our audience is very interested with your presentation. And we will break for 5 minutes. We will back with questions and answers session.
Thank you.
Thank you.
LifePack 20E. LifePack 20E adalah mesin defibrilator manual yang diperuntukkan untuk para profesional kesehatan. Penggunaan LifePack 20E sangat simpel. Cukup dengan langkah 1, 2, 3. 1. Untuk menyalakan alat. 2. Untuk menentukan besarnya energi kejut yang diberikan. 3. Untuk memberikan kejutan. untuk keamanan, apabila petugas tidak menekan tombol kejut dalam 60 detik, LifePack 20E akan membatalkan pemberian kejutan. DeFib ini juga dilengkapi dengan panduan suara metronom untuk memandu kecepatan RJP atau resusitasi jantung paru, untuk kompresi dan ventilisasi yang diperlukan pasien. Terdapat 4 pilihan panduan suara metronom yang dipilih tergantung dari kondisi pasien, yaitu untuk kondisi pasien dewasa yang tidak bernafas, pasien dewasa yang bernafas, pasien anak yang tidak bernafas, dan pasien anak yang bernafas. Heart Pedal LifePack 20E yang kami berikan merupakan model yang bisa digunakan untuk pasien dewasa dan pasien anak. Untuk pasien dewasa, plat besi yang digunakan berbentuk kotak. Sedangkan untuk pasien anak-anak, tidak perlu mengganti plat. Cukup menslide pegangan heart pedal untuk mengeluarkan plat besi berbentuk bulat kecil. Selain fungsinya sebagai DeFib manual, LifePack 20E juga dapat berfungsi sebagai AED atau Automated External Defibrillator yang bersifat semi-automatic. Sebagai pilihan upgrade, LifePack 20E dapat ditambahkan dengan fitur pacing dan SpO2.
Okay, Doc. We have many questions related to your presentation, but we have to choose 6 because of the time. So, number 1 question. In average, how many resuscitations conduct in the emergency department on daily basis, and how is the team is allocated?
I'm not sure I caught the last part of your question. I understand how many are how many resuscitations, and what was the second part of the question, please?
How many resuscitation conduct in the ED, and how is the team is allocated? I mean, how many people in the team during the resuscitation?
Oh, I see what you're saying. Yeah. Okay, so the number I can actually tell you is how many resuscitations we have in the community itself and how many of those get to the emergency department. So we have in Anchorage a town of 300,000. We have on the order of 250 or so cardiac arrests. About 200 of those are cardiac etiology as opposed to something else. And let's see, on the order of 100 of those go to the emergency department. So in terms of the resuscitations in the emergency departments themselves, you know, it's typically not more than 1 or 2 a day in the departments from either EMS or that they arrive or arrest in the department. The teams themselves within the emergency department, honestly, there's not a set number. Usually it's quite honestly more than you need. There's would always be a physician and perhaps 2, and then a team of radiology techs and respiratory and any other specialists that might be needed if a person had to go to the cath lab or the like. But in terms of a true orchestration like we might do in the EMS sphere, it's a little bit more random than that in my experience, honestly.
Okay, it's almost the same with us. Okay. So the second questions. Okay, this is about the ambulance, because the one who are working in the ambulance for us in Indonesia is doctors and nurse. We don't have any paramedic. So the question is, how is the ambulance team preparedness regarding to the COVID-19 pandemic?
Oh, how are they prepared for it?
Yes.
As it's happened with Malaysia and Indonesia, I'm sure as well, we had a lot of challenges to begin with, of course. the preparation started at our public safety access points, our dispatch centers, where we started doing questioning regarding symptoms to give us a heightened awareness of whether or not we might be encountering an infectious emergency. Now we've gotten to the point where we assume everybody has COVID, and of course most don't, but we assume they do. In my system here, we've moved on because we've had such problem getting all the protective gear, which is improving somewhat now. But our system went ahead and got these purified air devices. We have PAPRs that our teams wear basically all the time now as they go into a setting. And so that's been our most recent approach to it. Otherwise, we assess the risk, but in general, we're at least masked and then higher levels of respirators, depending.
Okay, thank you. So the next questions. Okay, this is about working shift hours. Is there an adjustment to the team working shift during the COVID-19 pandemic? It means if in the non-pandemic conditions, it's around 8 hours. It's become shorter or longer. Can you please tell us?
Is this with regard to residents, did you say, or everyone?
Everyone.
Well, when it first started, hours increased, but honestly, in the emergency departments, volumes decreased in most areas. Certainly, there was huge upticks in places like New York and the like, but in general, people were avoiding hospitals. And so there were, in fact, fewer emergency department visits by 20% or so. And so it became a kind of a challenging staffing environment. At the same time, because of the enhanced PPE that we had to use, it became less efficient. So it was almost kind of a good thing that there were less people because it took us longer to see people.
So you also have a decreasing number of people who are coming to the emergency department during pandemic?
That's correct.
Okay, also the same. Okay, next question. Okay, this is related to the referral flow. What is an effective referral flow for transferring COVID-19 patients according to their conditions, considering the health facilities in our place is also limited?
So the question is how we're transferring people with COVID?
Yes, from maybe rural area or remote area.
Yeah. So in Alaska, one of my tasks as the Stadium as medical director was to work on an interface with our military. We anticipated that usually our medevacs, our medical evacuations are done by private services, usually using jets in our environment. We thought they would be overwhelmed, and so we started working through the issues of using some of the military assets we had up here to transport people. And so we had something in place to move large numbers of people. We anticipated that we would be taking patients from even some of the, this will sound bad, but larger small hospitals, so hospitals that could provide some ICU care in some of our other areas, taking all of those people, if they're on ventilators, into Anchorage as centers of excellence, given the fact that we felt that people would have to have a very high level of expertise to manage these ventilator patients. It turns out that really never happened for us yet. We had patients, we've had deaths certainly, but we've never gotten to the point where we were overwhelming our resources in moving people. So our usual methods of moving them using our private air ambulance services has worked out fine.
Yes, this is what different from us because we don't have that kind of any resources yet. Okay, the next questions. Okay. So this is also asking about real situations in Alaska related to COVID-19 pandemic.
Unrelated to COVID?
Related.
Oh, related to COVID.
Yes.
So what types of situations are we talking about?
The real situation. Real situation.
Oh, our current situation on the
yes.
ground?
Yes.
Yeah. So again, it's kind of interesting. We are now seeing more COVID cases than we did earlier in the pandemic. They are less sick, and we aren't at the same level of alert that we were before. So it's not business as usual by any stretch of the imagination, but we are kind of in the mode of just taking care of people, whereas before we had all kinds of decon areas, and a lot of the hospital space was dedicated to areas to kind of segregate people and move them through. And now, I don't know, we're just kind of getting into a mode where we're not quite on that same level of alert. I think some of it has to do just with the fatigue of dealing with this pandemic, and people, just aren't quite as, I guess, what we call worked up about it as they were before.
Interesting, Doc. Okay, next questions. This is the last questions that we choose for you. Oh, this is about medical insurance coverage. How medical insurance coverage for COVID-19 case in Alaska? How wide is medical insurance coverage? It is paid all by the insurance, or they have to buy it? Have to pay it privately?
Right. No one answer for American healthcare. So again, if you're an Alaska Native or from a group that has some type of entitlement, then you would have free healthcare. So Veterans Administration, you wouldn't pay any copay or have dollars out of pocket. If you're on Medicaid, so the relief, and also with the Obamacare, some of that's Medicaid, you wouldn't pay. If you were paying for it out of pocket, then it's a large amount of money. I can tell you my own personal insurance. I'm privately employed in my EMS, in my emergency medicine group, and I have 4 kids. They're out of the house, but so a family of 6, I would pay about $45,000 US for the health insurance itself, and then it would have a deductible of up to $7,500 per person, up to $15,000 for the family. So somebody like me could end up paying $60,000 US for healthcare and not really have any, and I'd have to pay up to $7,500 before my insurance started working, if that gives you an idea of one example. Mine may be an extreme example, but that's how it is.
Okay. Yes. Very interesting. So, Dr. Levi, because of the time, we have to end the session. Thank you very much for your sharing. This is very interesting. And I do believe that our doctors and nurses that join the webinar will learn many things from your presentations. Hope to see you again, and hope you and your family always in a good condition. Stay healthy.
Thank you so much. Thanks for allowing me to be here. Really appreciate it.
Thank you. Okay. Bapak Ibu dokter sekalian, demikianlah presentasi dari Dr. Levi, pembicara pertama kita. Kita akan berlanjut kepada pembicara kedua kita yang juga sudah sangat terkenal di area emergency. Beliau adalah Dr. Ali Haedar. Beliau adalah clinical lecturer dan konsultan emergency physician. Oke. Beliau menyelesaikan pendidikan spesialis emergency medicine di Universitas Brawijaya, Malang. Kemudian working experience-nya banyak sekali, kalau dibacakan ini kayak panjang ya. Jadi bagaimana kalau kita langsung menyapa Dr. Ali Haedar? Dr. Ali Haedar, apa kabar?
Halo.
Hai, selamat pagi. Sepertinya kita pernah ketemu ya. Di mana kita pernah ketemu loh? Ketemu di mana ya?
Ya?
Oh, sering kali. Baik. Apa kabar, Dok? Kayaknya agak-agak ngantuk nih.
Iya, saya baru selesai jaga tadi malam. Pagi ini.
Oh, gitu.
Baik.
Baik.
Night shift 12 jam.
12 jam. Everything okay di emergency department?
Ya, ada satu kasus yang tidak bisa kita selesaikan dengan baik, out of hospital cardiac arrest, di mana tidak terangani dengan baik, dan kebetulan teman sejawat kita sendiri.
Aduh, itu so sad. Related to COVID mungkin?
No, not related to COVID.
Oh,
It's
not related to COVID.
related to the ACS,
Oh,
actually. Yeah.
aduh, oke. Baik, Bapak Ibu dokter sekalian, kita sudah tidak sabar untuk mendengarkan presentasi Dr. Ali Haedar. Dr. Ali Haedar, silahkan kami persilahkan. Waktu presentasinya adalah 40 menit dari sekarang ya dok. Terima kasih.
Baik. Ya. Okay. And Assalamualaikum warahmatullahi wabarakatuh, and very good morning. Thank you so much for the kind introduction by Dr. Yuni. And first of all, I would like to express my gratitude to idsMED, especially to Bapak Rufi Susanto, the president of idsMED, and iLA, idsMED Learning Academy, for the opportunity to speak in this international webinar, especially for Dr. Julia Darmawan. Hello, Dr. Julia, how are you? And a warm welcome to Dr. Mike Levi, actually a friend of mine in the EMS field that I have known him since 2015 in Taiwan during the medical director workshop in conjunction with public access defibrillator conference. Also to all participants, thank you for joining us. Next slide, please. And I have nothing to declare. Next slide, please. Yeah. Just before I introduce myself, I would like to understand about your perception on EMS system in Indonesia. Do you agree that we have a standardized ambulance services system in Indonesia? Would you say yes or no? The polling is counting. Good. And the result, as you can see, is probably inconvenient truth. Yeah, next slide, please. Oh, still counting. All right. Okay, next slide, please. Yeah, I'm Dr. Ali Haedar, and I'm a clinical lecturer at Universitas Brawijaya and consultant emergency physician at Saiful Hospital. So actually, I have been in the field of EMS and pre-hospital emergency care for the past, let's say, 8 years, where I currently post vice chairman of Southeast Asia chapter of the Asian Association of Emergency Medical Services, and had some fellowships also on EMS in Singapore and Taiwan, and becoming instructor for the National Association of Emergency Medical Technicians. Next slide, please. Yeah. And why Indonesia should have the new standard for hospital-based EMS? Next slide, please. Yeah, because EMS is as important as a hospital, as the ambulance services in the pre-hospital setting, as important as in-hospital care. So for easier understanding, EMS, also known as ambulance services, are emergency services which treat illnesses and injuries that require an urgent medical response, providing out-of-hospital treatment, and as well as transferring the patient to the next point of care, which is definitive care. Next slide, please. Thank you. Until current time, we still hear from the public on their perception that by calling an ambulance, we'll put them ahead of the line. Ambulance is only respond to emergency scenes, and ambulance is only for transportation, similar form of a gun van. Probably those are myths, but probably these are facts as well. Next slide, please. So, but we think for sure that we all agree that ambulance should be a well-equipped and efficiently organized vehicle with advanced communications and technology that can bring needed medical supplies, personnel, and advanced life support care to the emergency scene. Next slide, please. Okay, let's find out from the data whether the public trusts our ambulance or not. Yeah, a lot of indicators that we must figure out. But from our research published 2 years back, only 11% patients are brought to hospital by ambulance without proper management, and 11% are died before they arrive at the ED. Next slide, please. Of course, we cannot do shifting the blame to the pre-hospital care in the ambulance simply because there are many components of EMS with the concept of get the right patient to the right place in the right amount of time. Next slide, please. Thank you. And the goal is actually to increase the probability of survival all the way to the definitive care. Next slide, please. Yeah. And I would like to know your perspectives again. Do you agree that all public service centers, or we call it 11119, are cover all emergency medical services costs in Indonesia? Whether your answer is yes or no. Okay. Still counting. All right. Yeah, okay. The result is not surprising me. Yeah. Okay. Go on to the next slide, please. Okay. So how is actually EMS system in Indonesia? Next slide, please. Yeah. So actually, the EMS system in Indonesia is an integrated emergency management system, or we call it SPGDT, with the National Command Center, or we call it NCC, as the call center, and the public service centers as the ambulance service provider. Next slide, please. All right. So the points are the pre-hospital EMS services will be able to do care in the community, care during the transport, or we call it access, and care on the arrival at the receiving health facilities if there is delay in seeking care access to health facility and the provision of adequate care at the facilities. Next slide, please. So we may say that the role of EMS is actually to minimize the poor outcomes, mortality, and long-term morbidity. Next slide, please. As our EMS system included an integrated emergency management system, or we call it SPGDT, actually the system should extend to disaster management. But with our current preparedness, we have to ask ourselves, are we ready for escalated number of patients, like in the mass casualty incidents and disaster? Next slide, please. Yeah, we have lots of challenges. Among these many challenges that we can thinking of, the number one challenge that we want to discuss more is that there are still only 205 PSCs out of 501 districts or cities. It is around approximately around 40% with limited ambulance services in their surface area. Next slide, please. And again, we would like to know, in general, from your own perspective, which one is better in providing ambulance services, PSC or hospital, from your own perspective? Still counting? Good. Thank you. And yeah, thank you again for taking the survey. Some say PSC and some say hospital. That's good. Maybe it is not depending on whether it is PSC or the hospital, but I think it is on the system itself. Yeah. Okay. Next slide, please. Okay, thank you. Let's talk about a perspective of EMS system Indonesia that probably we can achieve in the future. Yeah. So actually, no single EMS system in Indonesia. Mostly are hospital-based EMS system, but probably in Jakarta, the capital city of Indonesia, that has the EMS system established in 2010 by run by the provincial health offices. So we are going to talk more about the hospital-based EMS system. Next slide, please. Sorry. All right. So basically, there are 5 essential elements that should be included in a hospital-based EMS system. Not only the personnel, but also they have to be trained with a good communication system, transportation, including the ambulance, the vehicle, as well as the facilities and where they are going to send to the advanced care unit, the importance of public safety agency like a PSC, also including the consumer participant, the access to care, transfer to care, the standardization of a patient's medical record, to have the information, education, independent review and evaluation by the medical director, disaster linkage, mutual agreement, and the last but not least is the mutual agreement. Next slide, please. Next slide, please. All right. So talking about the personnel, probably in the urban area, since we have a public safety center, so the personnel they are coming from those public safety centers, and also the ambulance personnel. But something that we need to think of that, how about the rural area? Probably the best thing that we can educate them like citizen volunteers, park rangers, mountain patrols to be the personnel of the ambulance care. And next slide, please. So actually, I would like to introduce you to the terminology of emergency medical technician, or we call it EMT. So basically, the EMT, paramedic, nurse, and doctors are different profession. So we cannot call that we doctor and nurses are medic, and we doctors are medic and the nurses are paramedic. That's actually wrong. So EMT and paramedic are actually a different profession. So in well-developed countries like Singapore, Taiwan, and also in the US, we call it those who are working in the pre-hospital setting, we call it EMT, or emergency medical technician. So actually EMTs are divided into 3 levels. The first one is EMT1, and after that EMT2. Another one is EMT3, or sometimes we call it EMT paramedic. For instance, we call them a paramedics. Next slide. Next slide, please. Thank you. So as I have my fellowship in Taiwan 2 years back, so EMT in Taiwan is very advanced, and they are actually those who are working as an emergency technician are actually also firefighters. So this system, actually the EMS calls are divided by location, and dispatchers assign local fire station to respond to a EMS call. At all the local fire department place in their EMT teams in the fire station and train firefighters as EMT. So if you take a look at the picture in your right hand side, you can see that actually half of them are actually working as a firefighting. Half of them are working as paramedic. So both are firefighters and paramedics. Okay, next slide. Okay. Next slide, please. Okay, so how about the training? So basically in the current situation, since Indonesia do not recognize paramedic, we only have nurse and doctors, that's all. But we are thinking about the future development, whether we are going to train our nurses to be a paramedic. It means that they have the ability, the capability to work in the pre-hospital setting, because we do understand that working in the hospital setting is actually very different to working in the pre-hospital setting. And probably in the future, we don't know when, probably we will have emergency medical technicians also, like in Singapore, Taiwan, USA, and other well-developed countries. Next slide, please. Next slide, please. Okay, so as I previously mentioned that actually EMT, they have a EMT 1, 2, and EMT paramedic that also have been explained by Dr. Mike Levy. Yeah, and they need to go through EMT training, which requires several hours in academic and practical training. Next slide. So basically, the EMT's tasks are to do the like CPR, doing the AED, to do safe extrication, immobilization, as well as transportation. Next slide, please.
Okay.
Okay, and in the next levels for the EMT paramedic, or sometimes we call it them as a nurse paramedic if they are coming from the nurse. Okay, so they have a more advanced task like giving the nitroglycerin, epinephrine, inhaler, and other things. Next slide, please.
Okay.
Yeah, so the next important thing is the communication. Actually, Indonesia, we recognize the national emergency telephone number, previously 118, and then need to change to 119 with the more well-developed system. And actually, the communication is the essential front door of the EMS system. It is not only to obtain initial medical information properly, but also to dispatch appropriate personnel, and also to offer first aid information initially. Next slide. And about the call center, yeah. Actually, in Indonesia, the call center is located at the public safety center. If they do have the call center, otherwise they can go towards the NCC. Actually, it's for public access, so that's why the number is very simple. Like in Taiwan, it's actually very the same with Indonesia. They have a 119 telephone number as well. So this call center will dispatch of the appropriate vehicle and the personnel, and do also the hospital notification regarding the patient's condition, and do have the online medical control by the medical director. Next slide. Next slide, please.
Okay.
So if I talk about the ambulance as the transportation, so actually I'm talking about the emergency ambulance, not the kereta jenazah, not the transport ambulance. Yeah. In well-developed countries, again, actually they are divided the ambulance into two tiers. The first one is a basic life support ambulance, and another one, the advanced life support ambulance. So you can tell, yeah, you can tell from the name. Actually, the basic life support ambulance is only doing the basic life support, but advanced life support ambulance doing the advanced. Actually, inside of the ambulance, they have more advanced equipments to support to perform advanced trauma or advanced cardiovascular life support. So we call it ambulance 118 initially, but we changed it into ambulance 119 currently. And next slide, please. And then facilities is also important. Why? Because all of these emergency patients from the pre-hospital setting, they should be transported to the closest appropriate hospital. Again, to the closest appropriate hospital, not the nearest hospital. Let's say like the patient with the stroke, actually they have to be sent to the facilities with the stroke center. It means that the facilities has at least head CT scan. And also for those with trauma, the patient with the polytrauma, multiple trauma, yeah, should be sent to trauma center. And how about those with the ACS or with the ST elevation myocardial infarction? Actually, they need also to be sent to the facilities with the PCI centers if in the area is available. Next slide, please. So, of course, these facilities need to have advanced care units. Yeah, in the tertiary, they need to send the patient, depends on the case, of course, to the tertiary care facilities. It means that they can manage the trauma, especially the multiple trauma. Yeah. Neonates, intensive care, high-risk obstetrics, burn, spinal cord injury, neurosurgical, as well as for the cardiac care. Next slide, please. And yeah, so talking about the public safety agency. So actually, a long time ago, before we have a public safety center, yeah, PSC. So actually in Malang, we already have the Malang Trauma Services, yeah, since 1997. Actually, it is when I was still in the first year of medical school. So, so the concept is of the public safety agency is the EMS system should have strong ties with the police, search and rescue, as well as for the fire department. Next slide, please. And also, this one also important that the consumer participation. Yeah, of course. It's talking about more about the public support. Yeah, it's all about the political and also it's all about the financial. Actually, of course, we cannot support the system by ourselves. Yeah, but also the local government also important to support the system, and not only those, but also for the public that the lay public first aid training and the implementation of a universal telephone number system 118 or 119, yeah, should be introduced to the public. Yeah. Also, we are very proud that in our Faculty of Medicine that we have training for the public, like this Universitas Brawijaya Siaga Henti Jantung, that basically we are teaching the public, the communities, how to perform CPR. Next slide, please. As you can see from these pictures, that training for healthcare providers and community is very important for us. And yeah, we are happy to inform you that we have trained hundreds of lay persons since 2012, and we keep going on for this project. Next slide, please. And how about the financial support? Yeah, how about the coverage? So access to care is very important as well, that the all individuals have access to emergency care regardless of their ability to pay or type of the insurance coverage that they have. So basically this EMS system is a patient-only point of entry into the emergency care system. So that's why we need to collaborate with the national insurance coverage like BPJS. And next slide, please. Yeah, the number 10 is a transfer of care. So of course, the system needs to have a collaboration, needs to have a MOU with other hospitals. Not only those with the high-ranked hospital, but also with those a lower level of hospital like hospital C and D. Because of what? Because they are transferring and transferring the patient to you, and you need to receiving you as the receiving facilities, and so that's why you need to have a transfer agreement. And one thing also important that probably whenever your hospital have emergency situation or disaster situation, like you have like in the how to say the earthquake, probably of course you cannot manage your patient in your own hospital. Probably you need to send your patient to transfer your patient to other hospital. So that's why transfer agreement is very important, but we are not going to discuss more about that one. Yeah, okay. So next slide please. Yeah, number 11, the patient records. So if I ask you whether your ambulance, do you have your own pre-hospital medical record for the ambulance? Yeah, probably some of you will say yes. Some of you will say no. But this is really unfortunate that actually different hospital, different public safety center ambulance, they have a very, very different medical records for the patient. So, so what we are trying to propose is that we need to use a similar reporting form. Yeah, so it would be easier for collecting the data for the that area or the national event. Yeah, so the record system should facilitate data extraction for trauma registries, severe scoring, and even cardiac arrest outcome studies. Yeah, so this in the picture, this is actually what we have in Malang. Yeah, and next slide, please. Thank you. And public information and education is also important, because the benefit from excellent EMS system that we need to prepare for the first aid care. As you know that the first aid care is actually can be done not only from us as from the medical side, but also from those from the layperson. So know how to quickly access the EMS system is also important. Understand that patient may not be delivered to the hospital of their choice under life-threatening condition is also something very important. Yeah, next slide, please. Yeah, so actually I have this picture whenever I have my fellowship in Taiwan two years back. So Prof. Chiang, okay, the one is standing there is Prof. Chiang. Actually, he is acting as a medical director of EMS base or PSC, yeah, a public service center. So the number three, the important is the independent review is an evaluation. So what actually Prof. Chiang's do is he's acting as a medical director. So that's so this is the importance of the EMS base should have a medical director, because he can help to review the EMS system, whether everything is running well, review of the communication, including all the problems, challenges, review of the response time, whether it meets the how to say the standard, to review the patient care, and also to check for the quality control. So the review of the outcome studies of several entities as cardiac arrest, multiple trauma, and etc. So it will help to advance our EMS system, and also to have the hospital participation as well. Next slide, please. The next slide, please. Yeah, the next is disaster linkage. Yeah, so you know that currently we call Indonesia the laboratory of disaster. Previously, Indonesia was a hypermarket of disaster, but we changed from the supermarket to hypermarket, from a hypermarket to laboratory. Why? Because we have to learn a lot of things from the disaster. Yeah. So for the disaster linkage, actually the EMS system is the integral part of the disaster preparedness, as in the SPGDT. So it should be involved in planning and practice the drill as well. So the EMS system inform of potential disaster situation as well as as well as the hazard. And probably we need to have the simulation for this one. We are going to discuss this next. And the EMS system inform of hospital capacity to receive certain kinds of patients under disaster conditions. Next slide, please. So yeah, this is the drill. Actually, it should be yearly joint exercise with multi disciplines, multi professions, and multi sectors. But yeah, we do understand that to conduct this kind of drill, there are a lot of money that have to be spent. Yeah. So for the mass casualty incident and also disaster drill is also important for the EMS. And the next slide. The last but not least is the mutual agreement. Yeah. So networking is very important. Yeah. So let's say whenever you have mass casualty incidents, you are going to receive 150 patients to your hospitals. Yeah. And they need the ambulance. The problem is, of course, the numbers of the ambulance, the numbers of the human resources will never be enough for that one. So that's why networking with other hospitals is also important. Okay, let's say whenever many of the patients are directly sent to your hospitals, probably your hospital will be collapsed because you cannot manage all the casualties at one time in your hospital. So mutual aid agreements is important. To not only to dispatch whose ambulance are going to where, and also to where to send the patients to. All right. And next slide, please. So from my point of view, from my discussion here, that yeah, actually there are potential advantages of hospital-based EMS. So that's why the hospital-based service included the ability to obtain additional in-house cross-training and educational opportunities that we have to think of. We can do the follow-up to patient interventions as well as the outcomes, and inclusion in a system that oversaw patient from the 911 or 119, sorry, call through discharge. And we can do the inter-facility transfer staffing, simple to arrange if specialist doctors, nurses, or other provider was needed. So that's quite different PSC and hospital. That of course at this point of time, probably the PSC do not have specialists there, but in the hospital they have a specialist. So whenever it is necessary, we can dispatch the ambulance with specialist doctors or nurses on board to transfer the patient. And the last but not least is the hospital staff gained a better appreciation of the skills set pre-hospital staff process when we're called to assist with in-house emergencies. Yeah, next slide. Next slide. Okay, another polling, the last one. So, do you think it is feasible for your hospital to apply these 15 essential elements of EMS system? You're counting. Yeah. Thank you so much for being positive. Yeah. Yes, of course. Yeah. So it's something very doable. So remember these 5 15 essential elements of the EMS systems. And next slide, please. Next slide, please. And as a conclusion, as a conclusion, yes, of course, we do understand that the EMS is a big system. So the EMS personnel with sufficient education is actually the fundamental of EMS system. So something we need to think of that probably volunteer sukarelawan is probably not enough to work in the pre-hospital setting. But of course, we need to educate them. And thanks to also to Perdamsi, last year, we do have a training to teach our EMS personnel coming from the volunteers. And probably it can be copied by other hospitals or universities also to help the PSC to teach their personnel. And the third is the hospital-based versus PSC-based EMS system. Of course, it's still debatable, but there are many things that we can do more. And SPGDT with its spaces are need, of course, to be improved. And until current time, there's no unified EMS system in Indonesia. So the last is, of course, hospital could help. Next slide. And yet it is far better to light the candle than to curse the darkness. Do everything that you can do everything that you can help to improve our EMS system. Next slide, please. Thank you so much, and I do hope that you gain a lot of information from me, and I will be very happy to accept your question. Thank you very much. Go back to you, Dr. Yuni.
Dr. Ali Haedar, thank you for your very interesting presentation. Why I feel that our second presenter is also a native speaker. Why? Are you a Singaporean or Malaysian or Indonesian? Why you speak in bahasa Inggris?
Yeah, because I had been sometime in Singapore, for quite some times, and at that time when I had my fellowship, I had to manage at least 10 patients a day, and you know that the Singaporeans are very demanding. If they are managed by a non-local doctor, so they will feel very upset. So that's why I'm trying to mimic them. The best thing to mimic them is trying to to mimic their accent. So that's why my accent is quite Singlish.
Singlish. Oke. Bapak Ibu dokter, jangan khawatir, Dokter Ali Haedar mengerti bahasa Indonesia. Jadi kalau memang ada pertanyaan boleh ditanyakan dalam bahasa Indonesia. Kita akan kembali 5 menit lagi setelah iklan berikut. Segera scan barcode-nya kalau ada pertanyaan dan tanyakan saja dalam bahasa Indonesia. Dr. Ali Haedar jangan kemana-mana ya, kita akan kembali 5 menit setelah iklan.
LifePack 1000. LifePack 1000 defibrillator adalah defibrillator yang mudah digunakan dengan didukung peralatan yang canggih dalam proses penyelamatan nyawa pasien. Dengan menggunakan LCD yang besar, sehingga mudah dibaca dalam memberikan informasi. Alat ini dilengkapi dengan suara yang keluar secara otomatis untuk menuntun pengguna dalam tahap penanganan emergensi, baik penggunaan medis ataupun non-medis. Alat ini juga dapat dipakai pada pasien pediatrik kurang dari 8 tahun atau pasien pediatrik dengan berat badan kurang dari 25 kg. LifePack 1000 juga dilengkapi dengan 2 tipe. Yang pertama, baterai lithium manganese dioxide baterai yang tidak dapat diisi ulang. Dan tipe kedua, lithium ion baterai yang dapat diisi ulang. Kapasitas LifePack 1000 ini dapat digunakan sampai dengan pemakaian sampai 440 kali secara otomatis.
Oke, kita sudah kembali lagi dengan beberapa pertanyaan untuk Dr. Ali Haedar. Jadi pertanyaan sebenarnya banyak banget, Dokter. Tapi kita akan pilihkan 6 karena memang waktunya sangat terbatas. Kita mulai dengan pertanyaan pertama. Jadi kita tahu kalau Indonesia itu trafficnya sangat bad. Ya, jadi ini dokter mungkin punya cara related untuk isu ini?
Okay, thank you so much. For a question from Hakim. Okay, so okay, may I speak in Bahasa or not?
Yeah, of course you can speak in Bahasa Indonesia. It is better for me.
Okay.
And also for the audience.
Jadi pada dasarnya adalah ada banyak hal yang sudah dikembangkan di Indonesia. Jadi ini bukan pertama kalinya di Indonesia kita punya ambulans dalam bentuk motor ya, sepeda motor. Jadi sebetulnya misalnya ada kejadian suatu cardiac arrest, out of hospital cardiac arrest. So you know that it will be very difficult for an ambulance to go towards the road with the heavy traffic jam. Tetapi kalau kita menggunakan sepeda motor pasti akan jauh lebih cepat. Jadi at least yang bisa dilakukan di situ adalah nomor 1. Misal, ya begitu dia menelpon ambulans 119, ya terus kemudian apa yang bisa dilakukan dari call center. Jadi dispatcher itu membantu untuk melakukan mengajarkan bagaimana cara melakukan high quality CPR atau kita sebut dengan dispatcher assisted CPR. Ya, jadi kita kasih tahu pada mereka, oke, letakkan tangan Anda in the bear dengan baju terbuka, terus kemudian taruh tangannya, terus kemudian ikuti irama dan lain-lain. Sembari itu dilakukan dispatch yang pertama adalah dikirimkan sepeda motor dengan seorang personel paramedic yang kemudian juga membawa AED dan obat-obat terluka. Terus kemudian menyusul kemudian adalah ambulans. Jadi sebetulnya ini untuk menjembatani antara sebelum ambulans yang mobil itu datang. Tetapi tindakan-tindakan di pre-hospital itu tidak kita tinggalkan.
Okay. Jadi begitu ya Pak Hakim. Jadi saran Dr. Ali Haedar adalah kita bisa mengkombinasikan antara ambulans motor dengan ambulans yang biasa. Jadi ambulans motornya bisa dispatch duluan, bisa duluan melakukan pertolongan sebelum ambulans yang reguler itu datang. Oke. Pertanyaan kedua. Pertanyaan kedua ini dari Putra Agina. Putra Agina ini menanyakan pertanyaan yang sama tadi kepada Dr. Levi. Ini ditanyakan kembali kepada Dr. Haedar. Ini adalah effective referral flow for transferring COVID-19 patients according to our conditions.
Okay, Putra, thank you so much for the question. It's a very good question, but actually currently we're not discussing about the COVID-19. Yeah, but something for sure that actually we can add on regarding the COVID-19 into our protocols. Jadi misalnya kalau selama ini kita hanya menanyakan, lewat telepon yang bisa ditanyakan kejadiannya seperti apa, terus kemudian dia tidak nafas dan lain-lain ya, terus kemudian dia nanya apakah dia dia sadar atau tidak. Misal kemudian kalau dia tidak sadar kita tanya apakah dia terlihat bernafas atau nafasnya tidak normal, terus kemudian langsung kita perintahkan untuk melakukan CPR. Misal seperti itu. Tetapi hal tersebut seperti ini kita harus melakukan yang kita sebut screening terlebih dahulu, dan screening itu kita bisa lakukan on the phone untuk menyingkirkan, dan kita sudah mungkin kita pada kesempatan lainnya bisa membahas lebih lanjut karena terkait dengan protokol ini ada banyak hal yang spesifik, dan yang paling utama di sini adalah bahwa keselamatan dari tenaga kesehatan adalah hal yang sangat penting buat kita. Jadi screening adalah suatu hal yang penting. Terus baru kemudian ada beberapa hal yang juga harus disesuaikan apa yang bisa dilakukan oleh tenaga lay person tersebutnya untuk membantu keluarganya. Jadi ada beberapa yang harus kita adjust. Oke. Mungkin
Terima
kita bisa
kasih.
bahas lebih lanjut,
Karena kita nggak ngomongin tentang COVID nih ya.
panjang.
Jadi secara garis besar yang penting Pak Putra ini adalah proses screeningnya. Jadi sebelum kita dispatch ambulansnya atau timnya, lakukan dulu proses screening yang mostly adalah by phone. Ya, oke. Next questions. Pertanyaan selanjutnya adalah terkait apa yang harus kita lakukan kalau lihat ada orang pingsan di jalan? Apa kita tinggalin atau gimana? Boleh tolong dibantu nggak dijawab ini dokter?
Oke. Jadi ya benar. Jadi ini juga terkait dengan COVID-19 ya. Jadi sebetulnya bantuan kepada orang lain itu adalah satu hal yang universal ya. Kita harus membantu sebetulnya, tetapi lagi-lagi terkait dengan masalah precaution adalah satu hal yang penting. Maka dari itu pada saat ini kalau Anda perhatikan seperti American Heart Association juga mengeluarkan suatu standar ya yang sebagai interim ya atau tambahan terhadap protokol yang sudah ada. Jadi ada hal yang bisa kita lakukan. Misalnya kalau kita terpaksa untuk melakukan CPR ya kita harus menutup mulutnya dengan kain dan lain-lain. Dan ini sebetulnya sudah jelas. Anda bisa melihat di beberapa guidelines baik dari American Heart Association, ESC dan lain-lain. Mereka semua mengeluarkan interim guidelines untuk ini.
Oke. Baik, selanjutnya pertanyaannya adalah terkait dengan overcrowding di emergency department. Jadi bagaimana yang harus dilakukan kalau ada pasien yang nggak dapat tempat di UGD? Ini common biasanya nih di UGD kita.
Ya, ini pertanyaan dari Vanessa Silalahi ya?
Bukan, dari Pak, is it? Iya ya.
Oh iya, halo Mbak Vanessa dari UGM ya. Jadi saya ketemu waktu beliau fellowship intensive care ya di Surabaya. Apa kabar? Oke, terima kasih banyak atas pertanyaannya ya. Bagaimana pengalaman jika pasien yang tidak mendapat tempat di UGD? Bagaimana pelaksanaannya? Jadi memang pada saat ini kita sangat beruntung ya, karena pada era BPJS ini kita sudah punya yang kita sebut dengan SISROAD, sistem sistem rujukan terintegrasi. Jadi tidak melulu pasien itu bisa dikirim ke rumah sakit rujukan tipe A, tetapi dari D, C, B, dan kemudian A. Satu itu. Yang kedua juga dengan sistem yang terintegrasi ini, apalagi kita sudah memiliki yang kita sebut dengan dashboard ya. Semuanya terekam dengan baik di situ dan kita berkomunikasi dengan baik. Jadi sehingga kita tahu kapan dan bagaimana kita harus mengirimkan pasien. Jadi sehingga tidak membuat rumah sakit kita menjadi overcrowding, jadi sehingga kita tidak perlu mengibarkan bendera putih dan kemudian kita menyatakan rumah sakit kita full house ya. Jadi harapannya adalah dengan sistem SISROAD ini bisa membantu sistem. Dan kedua, misalnya kalau kita sedikit mengkaitkan dengan masalah COVID-19 ya. Jadi pada saat ini dengan platform sistem yang sama ya, kita di sini bisa melihat bahwa screening berjalan dengan baik, terus kemudian sebelum pasien itu dikirim, kita sudah mengetahui dulu apakah fasilitas yang akan dikirim ya, atau kita sebut dengan receiving facility, itu sudah siap atau belum. Karena kesiapan itu bukan hanya sekedar UGD ada tempat atau tidak, tapi kita harus melihat apakah ada ruangannya, terus kemudian kita harus melihat apakah ada DPJP yang bertanggung jawab untuknya. Hal-hal itu harus kita pikirkan, jadi sehingga tidak melulu kalau kita melihat dashboard kesediaan tempat tidur dan kemudian itu menjadi satu-satunya parameter bahwa kita bisa menerima pasien tersebut. Tapi di dalam rumah sakit, terutama untuk terkait dengan masalah patient safety, banyak hal yang harus kita begitu. Semoga berkenan, Mbak Vanessa.
Terima kasih Mbak Vanessa Silalahi. Kemudian pertanyaan selanjutnya adalah dari Pak Bambang Sudono. Ini mengenai tantangan dan kurang lebih dari pengembangan IMS berbasis setting PSC 119 dibandingkan dengan community base.
Oke, iya. Jadi sebetulnya jadi salah satu komponen dari PSC sebetulnya adalah juga memang harus melibatkan dari community. Karena memang kita tidak bisa bilang PSC itu berdasar hanya dari community ya, karena memang PSC ini pun harus dikelola secara profesional oleh dinas kesehatan, kemudian dapat dukungan dari pemerintah Kota Madya, pemerintah kabupaten dan lain-lainnya ya. Jadi sebetulnya kita tidak membaginya, tetapi PSC itu merupakan bagian dari di dalamnya ada unsur-unsur dari community base. Dan jadi mungkin bisa saya kembangkan ini ke arah pertanyaannya, ke arah plus minusnya ya, mengembangkan IMS ini yang berbasis PSC atau berbasis hospital. Kalau kita lihat di sini bahwa dua-duanya sama-sama punya plus dan minus ya. Jadi contohnya, misalnya kalau kita menelpon ambulans ke rumah sakit tertentu, maka yang terjadi adalah pasti menunggu ambulans dari rumah sakit tersebut. Walaupun ambulansnya mungkin sedang sibuk ya, karena sedang mengantar pasien. Tetapi terus kemudian misal sudah menjemput dan pasien ini pun juga harus dikirim ke rumah sakit tersebut karena ambulansnya adalah milik rumah sakit tersebut. Padahal kita tahu tidak semua rumah sakit memiliki trauma center, tidak semua rumah sakit memiliki PCI, trauma, stroke center, burn center, dan center-center lainnya seperti itu. Nah, jadi ada kesulitan di sini dalam hal melakukan transfer. Yang sering terjadi adalah dikirim dulu ke rumah sakit tersebut, baru kemudian dirujuk. Yang dirugikan adalah pasiennya, waktunya, kemudiannya tindakan yang tidak penting, dan pembayaran, dan lain-lain. Ya, itu jeleknya. Maka dari itu, di Malang, dulu kita pernah, sebelum zamannya ada PSC, kita sudah membentuk yang kita sebut MTS, Malang Trauma Service Center. Ini merupakan sebetulnya cikal bakal dari PSC yang baru beberapa tahun ini dikembangkan ya. Jadi intinya adalah dulu tuh sampai kalau kita menelpon ke 118 sebelum ada 119, so actually we will be directed to the nearest hospital with the trauma center. Jadi ada beberapa area, saya agak lupa karena waktu itu saya masih mahasiswa semester awal ya, jadi tidak begitu paham dengan baik sistem yang ada. Tapi intinya adalah setiap kali kita telepon itu akan didirect ke rumah sakit terdekat yang memiliki trauma center, dan itu bagus sekali. Jadi sehingga ambulansnya juga ambulans yang dekat dengan tempat tersebut, dan karena ada kerjasama yang bagus, waktu itu kita lihat ambulans di Kota Malang, semua ambulansnya warnanya sama, bentuknya sama, kotak-kotaknya sama, ini sama, dan bagus sekali. Jadi sehingga dengan agreement yang ada, kita tidak melulu hanya memanggil. Kalau kita manggil ambulans, tidak melulu hanya dari satu rumah sakit atau dikirim ke rumah sakit tertentu. Dan harapannya pada saat ini dengan adanya sistem PSC seperti ini, keadaan bisa seperti itu ya. Jadi tidak melulu kalau nelpon ambulans harus ke rumah sakit tertentu. Tapi dengan sistem yang bagus dan integrasi, dan harapannya PSC juga bisa menggandeng dengan baik rumah sakit yang ada ya. Ini akan baik sekali. Contohnya juga bisa saya jelaskan di beberapa kayak teman-teman ya di Tulung Agung, kemudian juga di Mataram. Kalau kita melihat ada kolaborasi yang bagus juga ya antara PSC dengan dengan rumah sakit. Kalaupun misalnya PSC yang seharusnya letaknya berada di luar rumah sakit belum bisa ya, tetapi mungkin yang terbaik yang bisa kita lakukan. Jadi kolaborasi adalah suatu kunci. Terima kasih. Mungkin begitu Dr. Yuni.
Baik, terima kasih. Pertanyaan selanjutnya dari Dr. Agung Sugiarto. Jadi ini bertanya kepada Dr. Ali Haedar, kiat dan trik yang terbaik agar kru ambulans itu bisa segera cus gitu di masa pandemi COVID. Karena kan harus pakai APD level 3. COVID is so popular. So every question is related to COVID.
Yeah, that's true, Dr. Yuni. Simply because from our previous webinars, we are always discussing about particularly about COVID-19. Jadi masih ke bawah-bawah. Tapi that's okay ya. Jadi kalau pertanyaannya adalah seperti ini ya, jadi tergantung ya. Jadi mungkin intinya begini. Kita ada beberapa hal yang harus kita pertimbangkan bahwa nomor satu ya, tidak semua pasien itu COVID ya. Yang kedua, bahwa APD itu adalah sesuatu yang mahal. Ya, terus kemudian pemakaiannya dan lain-lain juga kalau sudah kita pakai, kalau kita buka mungkin nggak bisa kita pakai lagi ya, karena mungkin kalau dia reusable harus cuci dan lain-lain. Jadi waktu yang terbuang, extra cost dan lain-lain. Jadi seperti mungkin pada, saya sudah menjelaskan ini pada webinar sebelumnya ya, bahwa dari awal kita memang sudah melakukan screening dengan baik ya, lewat telepon. Dan kemudian menentukan apakah ini ada ke arah COVID atau tidak COVID-1 itu. Yang kedua, apakah mereka harus memakai semuanya ya? Sebetulnya tidak juga ya, seperti yang saya pernah share kepada Dr. Agung Sugiarto Masrum sebelumnya ya, yang pernah ada webinar dari Malaysia. Oke, di situ dikatakan dengan sangat baik bahwa kita prepare aja APD level 3-nya, tetapi begitu kita ke sana dan kemudian kita melakukan screening ulang, baru kemudian kita yakin ini adalah benar ke arah COVID, dan kemudian kita bisa pakai di sana on the spot. Hal-hal seperti itu, atau misalnya ada skenario yang lain. Jadi memang kita harus membagi ambulans kita, memang ambulans untuk yang khusus untuk kecurigaan COVID dan kemudian non-COVID. Jadi banyak skenario yang bisa kita lakukan, tapi pada intinya adalah kita tidak bisa mengatakan mana yang terbaik di antaranya, karena memang sangat tergantung dengan kapasitas dan yang dimiliki oleh rumah sakit ataupun PSG tersebut. Yes, begitu Dr. Agung.
Oke, terima kasih Dr. Haedar. Satu pertanyaan terakhir, tolong ini dijawab baik-baik karena saya tahu siapa yang bertanya dan saya tahu siapa yang membuat standar target 3 menit. Jadi masa depan saya tergantung jawaban Anda, Dr. Ali Haedar. Hai Dr. Sri Wahyuni, kenapa Anda bertanya? Oke, jadi mengenai apakah ada perbedaan standar waktu time to dispatch pada pasien yang biasa dengan pasien COVID? Karena di rumah sakit saya time to dispatch-nya adalah 3 menit. Selama COVID ini kami sulit untuk menerapkan karena pakai APD. Tahu lah ya rumah sakit mana ini?
Iya, ya.
Dari grup mana ini bertanya?
Jadi saya jawabnya ke Dokter Wahyuni Dian Purwati aja ya. Jadi pada intinya gini dok, ada yang mungkin kita mendengar konsep dari there's no emergency in pandemic. There's no emergency in pandemic. Jadi there's no emergency in pandemic bukan berarti artinya ya kita tidak perlu menangani emergency, itu salah ya. Tetapi lebih ke arah bahwa ya keselamatan kita adalah di atas keselamatan pasien. Jadi intinya adalah bukan standarnya adalah sebaik menurut saya ya, standarnya bukan seperti itu ya, harus 3 menit, tetapi dihitungnya adalah semenjak kita sudah menggunakan APD-nya ya. Demikian pula juga misalnya nih Dr. Yuni ada in hospital cardiac arrest dan kemudian Dr. Yuni harus mengaktifasi code blue sistemnya. Dan kemudian apa yang harus kita lakukan, apalagi itu ruang COVID ya, nomor satu adalah kita harus memprotek diri kita sendiri, kita pakai, baru kemudian kita melakukan manajemen. So that's actually what we call there's no emergency in pandemic. So basically it's very different to the normal setting ya, seperti yang dijelaskan kemarin oleh Dr. Yuni pada minggu yang lalu. Dr. Yuni menjelaskan tentang banyak hal yang harus kita rubah, banyak hal yang harus kita update ya, upgrade terkait dengan masalah sistem di UGD agar kita bisa melakukan banyak tindakan, banyak pertolongan buat pasien kita. Tetapi overall di atas semuanya bahwa lagi-lagi keselamatan diri sendiri adalah lebih penting, itu yang paling penting sebelum kita bisa menolong. Tolonglah diri Anda sendiri sebelum menolong orang lain. Bukan begitu, Dr. Yuni?
Bukan. Benar. Terima kasih ya, Dr. Haedar. Oke, Dr. Sri Wahyuni, jangan khawatir, saya sudah keluarkan itu dari Emergency Department Dashboard, jadi sudah tidak ada lagi itu dispatch 3 menit during pandemic. Jadi saya pastikan ya, tenang aja. Oke, Bapak Ibu dokter sekalian, demikianlah sesi bersama Dr. Ali Haedar. Terima kasih Dr. Ali Haedar untuk presentasinya yang sangat menarik, untuk jawaban-jawabannya yang sangat memuaskan. Oke, jadi Bapak Ibu dokter sekalian, ini adalah di akhir session untuk webinarnya. Terima kasih sekali lagi kepada iLA dan kepada PDEI atas terselenggaranya webinar pada hari ini. Saya akan kembalikan kepada host kita, Nurse Tommy. Silakan.
Baik, terima kasih Dr. Wahyuni yang sudah membawa webinar kita dari awal sampai akhir. Sebelum kita tutup acara ini, kita akan mendengarkan arahan dari Ketua Bidang Pengembangan Modul CPD, Pengurus Pusat Persatuan Dokter Emergency Indonesia, yaitu Dr. Eka Sakti Oktoharyanto, Magister Pendidikan Kedokteran. Kepada Dr. Eka Sakti saya persilahkan.
Baik, terima kasih atas kesempatan yang diberikan. Terima kasih juga kepada Dr. Ali Haedar, sangat bagus sekali. Thank you for Michael Levy dan juga Bu Dr. Wahyuni Dian yang telah membawakan. Terima kasih juga kepada idsMED dan Stryker yang telah bekerja sama dengan PDEI sehingga acara ini bisa berjalan. Emergency memang sangat penting, tapi seperti tadi disampaikan oleh Dr. Ali Haedar, memang no emergencies in pandemics karena COVID-19 ini berdampak banyak. Di dokter sendiri kita terpapar dengan kasus infeksi, mungkin ada violence, ada stigma, bahkan ada disturbance psikologik atau emosional, bahkan ada yang terpapar sampai bahkan ada yang meninggal. Nah, itulah sebabnya kita ada bahas tentang masalah second victim. Slide mungkin. Sedikit saya ingin memaparkan tanggal 17 September kemarin kita menerapkan World Patient Safety Day atau Indonesian Health Worker Safety Day. Ini disebabkan oleh stressful environment yang memang sangat besar di health worker. Jadi kita punya slogan sekarang Safe Health Worker, Safe Patient. Ini adalah tema sekarang. Karena ternyata banyak dokter atau tenaga kesehatan menjadi second victim. Awalnya second victim itu adalah diduga trauma karena apa yang telah mereka buat, error mereka sendiri, para nakes ini. Tapi ternyata dia tidak cuma dari error dari para nakes, juga ada dari kejadian yang tidak diinginkan dari pasien atau bahkan dari masyarakat yang seperti kita tahu kayak ada penjemputan jenazah dan lain sebagainya, itu akan menjadikan kita jadi second victim. Ada dua pendekatan. Pertama memang ini harus ditangani dengan cepat dan confidential, tapi karena pandemi ini akan panjang, berarti kita butuh ketahanan tenaga kesehatan. Dan ini kalau misalkan kita tidak tahan, banyak yang tumbang, akan ujung-ujungnya berpengaruh kepada sistem kesehatan nasional kita. Nah, berapa banyak yang terkena sebagai second victim ini? Antara 10-42% yang terkena dari 2013 penelitian SES et al. Atau bahkan penelitian terakhir menduga sebentar lagi all clinicians cepat atau lambat pasti akan terkena di second victim ini. Nah, bagaimana kita bisa mencegahnya atau apa aja second victim? Next. Nah, 2/3 itu tidak terlihat secara khusus. Biasanya cuma ya gangguan tidur atau bahkan wah saya jadi nggak percaya diri dalam menangani kasus yang biasanya saya tangani, atau ngerasa bersalah dengan wah pasien ini kok meninggal ya, atau saya kok tidak bisa mendiagnosis COVID ini dan lain sebagainya. Atau paling parah adalah kita jadi tidak profesional dalam menjalankan profesi kita. Ada PTSD atau bahkan sampai konsumsi alkohol, medication sampai ke arah meninggal. Ada banyak kasus terakhir yang kita tangani itu adalah ada yang meninggal di PPDS, itu baru-baru ini ya, dari bedah plastik. Seperti itu. Dan di sini sebenarnya akan berpengaruh ke bagaimana kita bisa menangani pasien ke depan. Jadi ujung-ujungnya adalah ke patient safety. Slide. Ada beberapa pendekatan. Paling pertama adalah peer support, kemudian ada briefing, Efektif yang briefing, mungkin singkat saja karena waktunya juga tinggal sebentar lagi. Boleh next. Secara umum saya membagi ke dalam 3 tier, 3 tahapan. Jadi pertama peer support dulu di antara masing-masing dokter, misalnya di IGD atau di tempat tertentu. Kemudian kalau misalnya diperlukan, dibuatlah ada orang yang khusus atau tim yang khusus menangani krisis ini, khusus second victim. Atau yang ketiga, kita bisa sewa psikolog atau psikiatri yang khusus untuk professional support network. Nah, 3 ini diperlukan untuk pertama di future hospital emergency care, karena emergency care itu lebih banyak orang yang bisa mudah stres, apalagi di tengah pandemi yang berkepanjangan seperti ini. Next. Nah, ini adalah bagaimana kita bisa menjaga ketahanan para clinicians untuk bisa terutama di level emergency dan khususnya di pandemi COVID-19 ini, ada meaningfulness, comprehensibility, dan juga manageability. Jadi ini tidak hanya disalahkan misalkan wah si pasien atau si dokternya tidak terlalu disiplin dalam penanganan ke pasien. Nah, tidak bisa seperti itu saja, tapi juga ada berkaitan dengan support dari staff atau bahkan dari manajerial. Seperti itu. Dan perlu disayangkan juga, kami sangat berduka, next, sampai saat ini kita ini data yang diambil dari 2 hari yang lalu, kita ada 117 kematian dokter di Indonesia dengan berbagai macam penyebab. Lebih banyak di dokter umum, ada 62 orang, termasuk 3 guru besar. Ini adalah sebarannya, dan mereka pasti banyak terpapar di emergency care. Seperti itu, di layanan primer atau bahkan di tempat-tempat yang tidak mudah mendapatkan APD. Seperti contoh, banyak rumah sakit khusus rujukan COVID, mereka malah jarang terpapar oleh COVID-19. Justru yang mereka bukan rujukan COVID, tapi mereka menangani pasien umum yang kita tidak tahu sekarang pasien itu COVID atau tidak, akhirnya kena lagi ke tenaga kesehatan, khususnya sejawat kita. Oleh karena itu, sesuai dengan tema World Patient Safety Day 2020 ini, mari saya mengajak ke sejawat sekalian untuk lebih memperhatikan terkait kesehatan hard worker, tenaga kesehatan, tidak cuma hanya dokter, tapi juga mungkin perawat, bidan, atau segala support pendukung di rumah sakit kita, agar rumah sakit kita bisa terjaga dan kita bisa bersama-sama melalui pandemi yang sangat panjang ini, karena sampai detik ini makin naik, dan justru tidak terlihat lagi kapan flat atau bahkan gelombang pertama akan selesai, tidak terlihat lagi. Itu saja yang mungkin saya bisa sampaikan. Terima kasih atas kesempatan sekali lagi kepada idsMED dan juga Stryker. Semoga kerjasama ini lebih banyak lagi kita garap untuk bisa lebih meningkatkan kompetensi para sejawat sekalian. Terima kasih. Wassalamualaikum warahmatullahi wabarakatuh.
Baik, terima kasih saya sampaikan kepada Dr. Eka Sakti. Sekali lagi terima kasih untuk moderator dan juga speaker yang telah membawakan materi dengan sangat luar biasa, dan kita berharap kita semua mendapatkan manfaat dalam webinar ini. Demikian rangkaian acara webinar kita hari ini. Saya mewakili seluruh panitia mengucapkan terima kasih kepada seluruh peserta webinar. Kembali saya informasikan bahwa untuk memastikan nama Anda di sertifikat telah sesuai dan benar, harap mengisi form yang akan muncul setelah Anda keluar dari acara ini. idsMED Learning Academy selalu berkomitmen memberikan yang terbaik dengan konsep yang inovatif dan interaktif. Akhir kata, saya Tommy Wower, mohon pamit. Salam sehat, tetap semangat, tetap menjaga protokol kesehatan dengan mencuci tangan, menjaga jarak, dan jangan lupa memakai masker Respocare.